Mike, thanks for a great talk this morning. And Dr. Averkamp, you want to pop yourself on here and we're talking about breweries, right? Resident culture brewery. Is that what you have your topic is?
Yes, absolutely.
Perfect.
All right. Can you see my screen there?
We can, and we've got the right one. Go for it.
All right. Well, I'm Ben Averkamp, one of the PGY2s, the research resident this year, and we're going to discuss kind of all things cultures in orthopedic surgery. Disclosures, I have none. Many of us in orthopedics are very unfamiliar with the process of culturing organisms. We say, obtain a culture, and we'll see what grows. But what actually happens in this process? How do stats such as sensitivity, specificity, likelihood ratio, and pre and post-test probability play a role? What does the current literature recommend? And we get better at capturing organisms? And also, what are future directions? Beginning our foray into cell cultures, it's critical to understand why infections happen, and there are a multitude of reasons. For many patients, the risk of infection is increased just by their mechanism of injury. There are also unfortunate cases in lapses in sterile technique. Local endogenous bacteria and hematogenous spread can also lead to surgical site infections. We also know that there are risk factors that influence infection rates, such as anemia, length of stay, obesity, depression, HIV, among others. Additionally, the Academy has reported possible risk factors such as diabetes, tobacco abuse, cancer, liver disease, and hypertension. With that in mind, it's important to think about why diagnosis of infections matter. Although generally considered a rare occurrence in orthopedic surgery, one thing is certain regarding infections. They are expensive, and we are on the hook for them. This 2015 study out of Vanderbilt evaluated the true cost of infections in trauma patients. Ultimately, after looking over 1,800 patients with isolated fractures and randomly matching patients with similar injury, they found that the cost of total care for a patient was doubled from $57,000 to $105,000 per fracture episode when they developed an infection. Their findings also noted that there's no single driver of these costs. They highlighted numerous areas where we can improve. One specific area we can focus on as surgeons is improving early diagnosis. This can help decrease length of stay and improve outcomes and reoperation rates. Currently, how are most infections diagnosed? Via cell cultures. From the time of the ancient Romans through the Middle Ages, people believed in the spontaneous doctrine. That doctrine stated that living creatures could arise from non-living matter, and then such processes were commonplace and regular. With the addition of the contributions from Hooke and Leeuwenhoek in the 1600s, organisms were first viewed under a microscope, and the term cell was coined for the first time. Progress continued in the late 1800s when the cell theory was developed, and the first proposed method of cell culture was recognized. Advancement continued with Harrison, Burroughs, and Carroll throughout the early 1900s. In 1925, the American Culture Collection, ATCC, was established in Manassas, Virginia, which helped provide organization for this rapidly developing field. Throughout the early to mid-1900s, there was an explosion of some of the same technology that we still use to this day. Around the mid-century mark, technology focused on developing different media to help diagnose different organisms. In the late 20th century, the focus has shifted towards stem cells, genetics, and 3D mapping. Despite this, plated cultures today still dominate micro labs. Now, obviously, this is a virtual talk, but my best guess, if I were to take a poll and ask who has been to our main micro lab out by the airport, I wouldn't see many hands raised. And because of that, I think it's important to understand the flow of specimens and how we get answers with our cultures. Cultures obviously drawn in the OR or the ED, where it is sent down to the lab. At Maine, the gram stain is initiated by placing a small portion of the culture into a specific vial, which allows for the specimen to be spun in this cytospin for 4 minutes. Once the cytospin is completed, the slide is then placed on a silver plate and allowed to air dry. Once dried, it is mixed with methanol for 30 seconds and again allowed to air dry. The lab then uses crystal violet to stain the cell wall purple. The slide is then washed and then iodine is added to the crystal violet. Decolorizer is added next to wash away the purple. And finally, the addition of safranin is used to stain gram-negative bacteria if it's present. The slide is then moved to the microscope. While the slide is under the microscope, the lab evaluates for 2 things: bacteria and number of cells. Each of us remembers gram stain nomenclature from our first day in med school during 2nd year, and so I won't go into detail on that. However, rarely discussed is the quantification of cells under the microscope. There is some variation in literature. However, multiple orthopedic studies have reported few, moderate, and many as a classification system used to identify how many cells per high power field. This information is then reported to the EMR. Once the gram stain is completed, the culture is placed into an outgoing box or is transported to the core lab multiple times per day. This is an image of the main micro lab, which is run by between 8 and 12 lab techs during each shift. Once the cultures arrive via couriers at microlab, they're then placed in the stat bin for immediate plating, With 3 streaks of culture, the cells are usually plated on 4 different plates: KB plate for gram-negative, PA plate for gram-positive, blood auger for control, and an anaerobe plate. The anaerobes then go into these containers like that, where they are vacuum sealed to maintain an anaerobic environment. Every 24 hours, a tech will manually evaluate the slides to determine if growth has occurred. After the prerequisite time has passed, whether it be 48, 72 hours, 5 days, or 14 days for synovial culture, the culture will finally result. If we find positive cultures, antibiotic susceptibility testing is then completed. This takes around 24 hours to complete. It occurs by mixing part of the culture into a sterile saline bottle and spreading the bacteria over 96 mini Petri dishes to assess susceptibility for each preloaded antibiotic in specific quantities. This is then reported back to our team. With all that being said, what happens when we have a positive or negative culture? Is it really positive, or is it false positive? What about a negative test? Are we done? That's where statistics can play a crucial role in infection. In making a diagnosis, we are frequently dealing with a gray scenario more than black and white ones. Because of this, we must have a way to come to a diagnosis of whether this is septic or aseptic, whether it be a joint, an implant, or non-union. There are 2 ways essentially that we can begin to come to a diagnosis, or at least reach a point of conviction. The first is simply pattern recognition, then constellation of signs and symptoms. Or in the case of infection, frequently, we rely on probabilistic thinking and ultimately utilizing concepts such as pre-test and post-test probability. With that in mind, a refresher can be needed for many of us. In helping decide what test to use, we often consciously and subconsciously give a value to our pre-test probability of a disease. There are 3 main ways we can prescribe this technique. The first is through direct studies. We can ask ourselves, what is the prevalence of septic arthritis in patients who ED with knee pain? Maybe 1%. For many of us, we don't know this information, so therefore we don't use this information, as it is much more relevant for other medical specialties. There are things such as validated prediction rules, such as the Ottawa ankle rules or PCARN for pediatric head trauma. They give us generalizable risks. Finally, and least scientific, although probably most used, is guesstimation or clinical gestalt. Moving on to our actual test result, just a quick refresher on sensitivity and specificity. Sensitivity rules out, so SNOUT rules out, and it's good for screening, while specificity rules in and is ultimately used for making a diagnosis. Then thinking about, well, what do positive tests tell us? Does this person actually have the disease? And that's where positive predictive value and negative predictive value come into play. The problem with positive predictive value and negative predictive value is they are susceptible to the prevalence of a disease. So in a subset of patients who have classic presenting signs like a draining sinus, as noted in this image, the positive predictive value should be high for the test because we expect a very high percentage of patients with draining sinus to have an infection. But what about a slow-growing infection? This can be more challenging, and the positive negative predictive value can be much more misleading than helpful. As you can see, a smaller change in prevalence can lead to a greater change in the positive predictive value. That's where likelihood ratio can be helpful. It is used to assess how good of a diagnostic test is and help in selecting the appropriate tests. It is less likely to be influenced by prevalence and incorporates both sensitivity and specificity into one test. In general, when thinking about likelihood ratio, greater than 1 rules in and less than 1 rules out. A high likelihood ratio of greater than 10 is a very specific test which helps rule in a disease, and a low likelihood ratio less than 0.1 helps rule out a disease or is highly sensitive. Visualizing this on nomograms allows us to predict the post-test probability in a simpler way. Depending on test selection and likelihood ratio of the test, we can have a major impact on overall post-test probability in the diagnosis of disease. Take a patient with a pre-test probability of 50%. Utilizing 3 different likelihood ratios can produce 3 varied post-test probabilities. In the first patient with a likelihood ratio of a test of 5, you note that the post-test probability increases from 50 to almost 90%. Now, if the likelihood ratio is changed to 2, this increases the post-test probability to only 70%. What happens if we have a likelihood ratio less than 1? Well, this will decrease our post-test probability ultimately to under 20%. All that being said, let's look at the actual data. What's the official stance of the Academy on cultures? The update to the CPG in 2017 continues to reinforce the use of cultures in orthopedic surgery. Their statement strongly endorses cultures for infection, but also notes that negative tests don't rule out infection. Interestingly enough, the second portion of their statement indirectly describes sensitivity. Cultures is a broad term though, and especially for us residents, there are plenty of questions like, do gram stains help? How should we obtain cultures? How many cultures? What are the timing of antibiotics? What happens if cultures are negative? Before many of us even received the culture results, we were given the result of the gram stain. Although this study is dated that it first appeared 20 years ago, it is one of the early orthopedic studies I found evaluating different diagnostic tools in orthopedics, which continue to appear consistent with literature today. In this study, they determined that gram staining was horrendous at ruling out infection, i.e. sensitivity. However, they did demonstrate a strong ability to rule an infection if bacteria is found in a gram stain. How about a more recent study? Study out of the Rothman Institute from a few years ago evaluated gram stain in total hip and knee arthroplasty patients. They defined a positive gram smear as visualization of bacterial cells or many neutrophils, 5+ per high-powered field, on a slide. They looked at sensitivity, specificity, and predictive values and found that sensitivity to be especially poor. Gram staining failed to diagnose PJI in 47% of total knee and 69% of total hip patients. Stained organisms were only observed in 30% of total knee and 31% of total hip patients with confirmed infection. Ultimately, what these studies tell us is it's okay to continue utilizing gram stains as a diagnostic picture due to high positive predictive value and specificity, but to not rule out infection on the basis of a negative gram stain. One of the first thoughts we must have is how to actually obtain a culture. Is there a specific technique that is recommended or that improves their sensitivity or post-test probability? This prospective study evaluated 150 revision arthroplasty procedures performed over a 6-month span. They obtained 3 tissue cultures and 3 swab cultures simultaneously from the same wound. They found that tissue cultures were positive in a higher percentage of septic cases than swab cultures. Swab cultures were also found to have more false negatives and false positives than tissue cultures. Also, the likelihood ratio is much more robust in tissue cultures. They strongly advised against intraoperative swabs. Next question to answer is how many cultures should we obtain? On the previous slide, they used 3. And is there a reason for this? Most likely, yes. A study in 1998 determined that at the time, 3 or more positive culture samples are strongly predictive of an accurate infection diagnosis. By obtaining 3 cultures, it improved sensitivity to 66% and specificity to almost 100%. The likelihood ratio improved to over 100 with positive test results of 3 or more specimens. Going back to the nomogram that I described earlier, unless your pretest probability was less than 5%, which some may question why you're actually obtaining 3 cultures in the first place, your post-test probability of infection will be significantly improved by utilizing 3 or more cultures. How about fracture-related infections that are arthroplasty literature? This 2021 JVJS article looked to help clarify the number of cultures that should be obtained. Their goal was to estimate how the accuracy of different numbers of specimen and diagnostic cutoffs for micro-testing of deep specimen tissues. They recommend 5 deep tissue specimens, as this was where sensitivity was the highest. Do antibiotics impact our culture results? The answer depends. It does appear in multiple smaller retrospective studies that a one-time dose of pre-op antibiotics does not appear to impact or affect culture results. What about starting on broader systemic antibiotics before surgery? This New England Journal of Medicine study out of Mayo looked at 331 patients undergoing revision arthroplasty. They evaluated culture sensitivity based on the timeline of receiving antibiotics. They found a significant increase in culture sensitivity when antibiotics were delayed 14 days or more prior to surgery and culture completion. Sensitivity improved from 41.2% if antibiotics were administered within 3 days to 77% if they're held off for 14 days. Additionally, they evaluated the overall sensitivity of cultures when 2, 3, 4, and 5 cultures were obtained intraoperatively. The sensitivity improved from 50% with only 2 cultures to 72.7% with 5 cultures. The decision on how long to culture specimens in orthopedic surgery is knowingly a bit of a controversial topic and one that could easily use a full grant allotment for time. That being said, I feel this talk would be incomplete at least not discussing some of the current literature. The first study published in the Clinical Journal of Infectious Disease attempted to quantify and qualify this data. They looked at 284 patients with suspected late hip or knee infection. They compared histological analysis to microculture over a 14-day period. They determined that infection was found in 110 patients, of which only 74% were detected after culturing for 7 days. However, when 6 additional days were added, they were able to capture 100% of the infections. They reported that high virulent strains, such as staph, were detected early, while lower virulent strains, such as C. acnes, were determined late. They called prolonged culture promising. This wasn't the only well-designed study that recommended extending culture. A few years later, the study out of Seattle looked at cultures over an extended 28-day period. They recommended observing cultures for 13 days to detect lower virulent organisms again, such as C. acnes. After 14 days, they determined that the diagnostic accuracy did not improve. They only continued to find contaminants, or as they call them, non-diagnostic events. More recently, a study from Switzerland reined back in the theory that all cultures need to be observed for 14 days. prospective study looked at 499 tissue biopsy specimens from 117 orthopedic trauma cases. The median time to positivity was only 1 day, and 97% of infections were diagnosed within a 7-day period. They reported that only in specific cases should cultures be extended beyond 7 days, as at that point contamination increases much more significantly, while diagnostic utility does not increase much. This appeared more in line with current orthopedic trauma trends in fracture-related infection, especially in active purulent infections, where time to culture is normally short. Lastly, are there other general principles for obtaining cultures that we should follow? This article made a few recommendations for the less experienced surgeons. They recommend obtaining cultures at the implant bone interface. They also recommend that the target area is not manipulated, or as they called it, a no-touch technique. They also emphasize using separate, unused surgical instruments for each culture, and strongly recommend avoiding sinus tract areas or areas of superficial skin to prevent. Despite all these recommendations, what happens if our cultures are negative? According to this recent JBJS review article, they reported that 7 to 10% of PGIs will be culture negative, even if proper number of cultures are obtained and antibiotics are held. They postulated 4 reasons why this may be the case. The first is that implants may be encapsulated in a biofilm composed of macromolecules such as glycocalyx, which allows the organisms to evade host cells. These sessile bacteria can be 1,000 times more resistant to antibiotics than free-floating counterparts. A second reason for culture failure is an inadequate medium chosen for an atypical organism, such as fungi. Third is poor culture technique, which we just addressed. And lastly, we just don't obtain enough culture or improperly diluted culture to grow specimens. But circling back, how can we address this first obstacle? Sonication has been a described method to attempt to address biofilm conundrum. This is a concept where long-wave ultrasound is used before a culture is obtained to disrupt biofilms and free pathogens. This 2010 study out of Austria looked at improving pathogen detection with PJI. Explanted components with presumptive prosthetic or implant infection were sonicated separately in sterile containers. They found that tissue culture after sonication significantly increased detection of infection when compared to tissue alone. They also found that even after patients who received prior antibiotic therapy, their diagnosis was still improved. Ultimately, regarding sonication, there are more studies than we have time for today that demonstrate improved diagnostic capabilities of sonication of difficult to culture infections. At this point, you're probably feeling like you're drowning in information, but to make it easier on everyone, here are just a few key takeaways from what we just discussed. Tissue culture is much better than swab culture. Really avoid using swab culture. Obtain between 3 and 5 cultures. Most people will recommend 5, but there's no need for more as you have diminishing returns. Pre-op prophylactic antibiotics don't appear to impact overall final culture results. If possible, hold off on systemic antibiotics for at least 14 days prior to surgery. And ultimately, the absence of a positive culture does not indicate that you're infection-free. Enough about the present. What are some future directions to make our jobs easier at identifying organisms? Molecular diagnostics is an incredibly broad field as indicated in much of the literature. That being said, there are a few areas that are showing more promise within this realm, although none are a perfect process. They are PCR, metabolomics, and personalized medicine via DNA profile. PCR is a molecular technology used to amplify a single copy of a piece of DNA to generate thousands to millions of copies of a particular DNA sequence, thus enabling rapid detection. It works by using nonspecific dyes that intercalate with any double-stranded DNA or nucleotide. That is then detected on a probe and can be reported. Ultimately, the number of rounds of replication that a DNA must go through can be recorded and help with determining the most common, most likely microbe causing infection. Well, how is the data? Okay, so far. The first published study about 20 of the UK created intrigue around this topic. It found great accuracy in diagnosing 120 total hip arthroplasty patients compared to histopathologic evaluation. Approximately 70% of the samples were positive in PCR and under histopathological evaluation. Concurrently, they compared this to cell cultures, which were only positive in 22% of the patients. One of the main takeaways from this topic was that they're most likely underdiagnosing infection with cell cultures. More recently, this 2018 study evaluated 142 patients, 82 knee and 60 hip, where PGI was diagnosed in 77 patients and aseptic failure was present in 65 patients. They found that culture sensitivity and PCR sensitivities were similar. Both PCR and cultures were concurrently positive or negative in 82% of the patients, indicating significant overlap in detection. They did find that PCR missed 6 high virulent pathogens such as staph, strep, or E. coli, while synovial cultures missed 12 mostly lower virulent pathogens. They recommend the inclusion of additional primers to assist with accuracy in attempting to make PCR, the gold standard. What happens if you pre-treat your patients with antibiotics? This Japanese study attempted to detect bacteria after specific insults that were applied to understand how long antibiotic treatment that these microbes are still detectable by PCR. They evaluated multiple bacteria such as MRSA, Staph epi, and E. coli. They found that non-viable microbes can be detected by PCR long after use. In MRSA patients treated with VANC, up to 8 weeks after patients may test positive on PCR. For linezolid treatment, this is even longer at up to 12 weeks. The literature also noted that for Staph epi and E. coli infections that were treated with ANSEP, non-viable bacteria was identified on PCR up to 20 weeks after antibiotic application. These results can be viewed in both a negative and positive light, depending on how you use them. Have you eradicated infections sufficiently, or are you able to pre-treat your patients with antibiotics knowing that they still will possibly test positive long after initial treatment? Study by Omar et al. In 62 consecutive patients over a 2-year period who underwent revision fracture fixation with subsequent complications. Classified subjects are infected. They classified subjects as infected if they presented with a sinus tract, open wound, gross purulence seen in intraop, or 2 or 3 tissue cultures testing positive for the same pathogen. They actually found that tissue culture was better at identifying infections and had notably fewer false positives. They recommended avoiding a swab PCR test. What about metabolomics? Metabolomics is a very complex field that involves studying chemical processes that produce metabolites. That being said, there's minimal literature in regards to it. However, there's promise in possibly beginning to identify injuries or infections through mass spectrometry of human plasma. It is currently far too expensive to be tested on a broad scale, though. And finally, DNA profile establishes a profile of the patient and infection through nucleic acid analysis. It allows for better diagnosis and more targeted therapy when studied to achieve much higher success or more chronic indolent infections. This, like other future thoughts, are still not ready for the prime time yet. I'd like to give a special thank you to Dr. Shu, Dr. Rice, Dr. Odom, and Dr. Haynes. At this point, I can open it up for questions.
Thanks, Ben. I think that this is obviously a very important topic. I just got to personally experience this last week, and this is what complicates the picture. You have a patient who's worsening clinically, has early loosening of an implant, elevated labs, right? Slam dunk, go in and, gonna have to wash it out. There's probably an infection. Go in there in her spine, 0 pus, nothing looks bad, just took cultures of the soft tissue. There was no fluid to culture, took deep cultures, everything you could think of. Had one loose screw that I was exchanging and decided to stick a pituitary down the pedicle to get some tissue culture from inside of that pedicle. Well, that is the only thing that grew, and it grew Pseudomonas. So, a relatively less suppurative, bug, just shows, emphasizes your point about that bone implant interface and how difficult these can be to just diagnose. It does feel like we really need to move beyond cultures into some new technology. Dr. Chu's got the answer for us, right, Joe?
I'm not sure I have the answer. I potentially add more controversy. Ben, I know you poured through the literature and you talked very well about pre and post test probability. One of the questions that I struggle with over my career is, especially in orthopedic trauma, has lagged a little bit behind the total joint literature, where they abandoned routine culturing for presumed aseptic cases based on the pretest probability being so low and your likelihood of having a false positive result. Could you comment a little bit on that aspect of when potentially should we not take cultures during revision surgery in a variety of specialties?
Yeah, well, I think, you kind of like to think about this like likelihood ratio, and really, I think I touched on it low. If your pretest probability is, if you're less than 5 or 10%, and maybe this is clinical gestalt or just overall appearance of an infection, I think at that point, you may be doing yourself more harm than good in really obtaining cultures. I think because your chances of having a false positive in such a low prevalence disease is more likely than that. And so I think honestly, if you're thinking that like less than 5%, that would be a number where I would really begin to question if obtaining a culture is best for the patient.
Eric?
Hey, Ben, I had one question for you, which was, in a lot of this with some of the newer techniques, what we seem to find is we're identifying bacteria in places where we don't expect it, or a whole host of bacteria, which has kind of led to the question in some circles of whether or not bone has a natural microbiome. When we know from studies of the gut and a lot of even therapy with the gut now with C. diff, that there's a natural microbiome in there of bacteria that's supposed to be there. Did you come across anything in that where it was delving into PCR actually giving us too much information and potentially just revealing what bacteria is supposed to be there and may not necessarily be pathogenic?
Yeah, one of the last studies I talked about with PCR, it found that PCR was actually giving us significantly more false positives than tissue culture was, and I think that probably did somewhat to your point that maybe this was staph epi or some other bug, which was more of like a naturally occurring bug, even though it's rare, that was impacting our results.
Ben, I think one thing that this, talk kind of emphasizes is that you really have to be a bit holistic about taking care of your patient, and having a conversation sometimes with the ID doctor is really important. For my case where I had a Pseudomonas positive, that's kind of a slam dunk. ID is like, this is not a contaminant, but so many times we get those questionable, is this, a contaminant? Is this, normally here? What do we do with this? So you really sometimes just have to say, despite a negative culture, the clinical scenario is X and we need to do Y. Because if you don't have that conversation sometimes, and I'm sure everybody has seen that in the hospital when ID lays a note down and you feel like they're going to undertreat the patient. So I think you really have to, have those discussions doctor to doctor to make sure that you're doing the right thing. Joe, you have another comment there?
Yeah, a couple of practical comments. Number one is if you're doing a culture around an implant, just put implant-related infection. There's a process in the system for periprosthetic infection for total joints. They didn't realize that there are other implants in humans that are not total joints. And so you just put peri-implant infection. We think we fixed the process. The reason why this becomes important is a gram negative staph will be discarded as contaminant and not go to sensitivity testing unless they think it's around an implant. And so if you put that, then and there's a staph epi, they'll continue to do those. The other thing is that there are standards of work for how to send a culture. We had a lot of problems for many years with cultures being discarded and not processed because they were quote unquote spilled if there was any contamination on the outside of the container. There's a standard of work, try to clean the outside of the containers and bag them separately individually so they don't discard it. They should still also process the culture anyway, even if it's spilled with a warning on it that it may be contaminant because it was quote unquote spilled. Most of these spilled cultures meant that there was a single drop of liquid on the outside of the container. And so if you have a situation where you have where it's spilled and they don't finish out with the culture, please let me know and I'll follow up with the lab on it.
All right. Well, thanks, Dr. Averkamp, Dr. Shalmo. A couple of nice talks this morning, teaching us a lot. And Dr. Mormon, thanks for your reminder about the upcoming U.S. News and World Report voting. Obviously, a very important topic. We'll make sure to touch on that a few more times and let everybody know at Grand Rounds when that is officially being distributed and open, because it is a important piece of the puzzle, that personal voting session. So thanks, everybody, and we will look forward to next week. We're going to have a great talk. I think Dr. Waters will be giving a talk, and we'll look forward to that. Thanks.